Welcome back, everyone, and thank you for bearing with us while we experienced some technical challenges. Before we dropped out, Dr. Buchanan was talking about the transpo process and what that is like for patients who are having to leave our jurisdiction. Dr. Buchanan, I bring it back to you.
Sure. Thank you. I suppose one of the best ways to kind of conceptualize how transport of a critically ill patient looks, I guess if you compare it to say like an egg race where you're carrying an egg with on a spoon, right? And you're carrying that and you don't want to drop it because you'll break the egg. But then you have to pass that egg off to someone else and they have to run as well as a relay. And that's very much like the handoff in a critical care transport. There are many potential problems that can happen, whether it's monitoring devices, breathing machines, for example. And our members of our experts, including ambulance staff, EMS staff, and air medical crew, they are very attuned to these problems. But they can be very difficult to detect, especially when you're, say, flying in the air at 25,000 feet. So that's certainly one big concern. Now, I just want to mention too that in the ICU, in the luxury of being in a place that's somewhat static, we do a lot of this proning thing, where basically we take someone who's on their back, and if they can do it themselves, we ask them to lay on their chest. But oftentimes, if they're on a ventilator, we actually have to get a very large number of staff, up to 6 to 7 nurses, respiratory therapists, and physicians to help actually take the patient, put them on their side, and put them on their chest in a way that's comfortable and doesn't give the patient any injury. And this is a very effective maneuver. However, this maneuver cannot be done in transport, and it's perilous. It's dangerous to do in transport, so it's not done because simply, it would be untenable level of risk. So we just can't do that, and so we're kind of left to make sure we pick the patients that will best survive transport, and that is actually quite challenging. We have patients who are on a ventilator for 6 days with COVID, and it might look like their oxygen requirements are even keel. But we can certainly see very sudden changes. And that can be because the disease itself, because COVID has worsened the lungs. That can be because they developed a blood clot in their lungs, because they developed a secondary infection. So, and these things can happen in COVID, in coronavirus, they're predictable, like on a global stat scale, but on the individual patient level, they can be less predictable. And so those things are kind of hard to mitigate in terms of transporting a patient. And those are concerns that we always want to make sure that we are addressing prior to sending anybody out.
One final question, or first question, final question for this moment before we go back into questions for you, Dr. Buchanan. You talked a lot about the flight team, the paramedics, flight physicians, folks who are up in the air and on the ground doing this transporting. How many of those folks do we have in Alberta? What type of resource does that in of itself? And so I guess, how many patients would it even be possible to transport if there was room in other jurisdictions?
Well, I think this is the question that I frankly am worried about. I mean, I routinely do a call with a number of different colleagues for STARS, and we see that the resources right now are stretched, and that includes resources like helicopters, planes, and ground ambulances. And really, we're talking about fixed wing or airplanes here. Now, I'm not exactly sure of the number of personnel staff we have for a medical crew within Alberta, but I wouldn't be surprised if the pool was around 100 to 200, for example. But of course, we have a high amount of need in Alberta because we ship people throughout this province in all directions because of the geographic nature of our province. And so I think our current resource demands are really high, and we already have issues with ground supports. So I think my suspicion is what we'd be looking at is recruiting other resources from, say, Ontario, if that's where they'd be shipped to. So perhaps we'd have to task a resource out of Ontario to come help a patient out of Alberta to bring them back. And then again, I have to really have some concern that they may also have issues that are impending with resource crunches. So these kinds of tools of caring for critically ill and transporting them are certainly highly specialized in a pretty highly used commodity. So I'm not sure how that would look. I mean, there's certainly been other places in the world in prior waves where they move people in bulk with big planes and trains and such. So, I think in some places I wonder if they would be involved into the military, for example, to use large capacity for larger transportation of critically ill, because having one person in one plane, that ties up a resource for somewhere in Canada, and I just don't know. I don't know how feasible that is right now, and it's just there's a lot of things in the air. I suppose that's a really bad comparison. There's a lot of calculations, I should say, that people are leery of, and I don't know how that looks at this point in time, given the high demands across all provinces.
Thank you very much. I'm going to invite Dr. Schutnate into the conversation to look at the third component of today's conversation. We know that our healthcare system is in a massive amount of transition in order to make the necessary accommodations so that we can avoid implementing triage protocols and ideally save as many Albertans as possible. You're joining us from a general and breast surgery background. Could you give us a bit of an overview as to what it has been like for you as surgeries have been canceled and you've had to shift, I suspect, some of your work?
Yeah, so obviously this has been an increasingly challenging area for all of the surgeons in the province, from cardiac to vascular to thoracics to general surgery, and we're having to shift our focus away from providing the care that we're used to providing the care that we would expect patients to benefit the most from, with very, very limited resources. And, in order to kind of understand where we're at with this, I wanted to just spend a few minutes briefly talking about how we manage waitlists in Alberta. Next slide, please. So in Alberta, we have this thing called adult coding access targets for surgery that I'll talk about, and that really helps us to manage our wait lists. And then I'll spend a little bit of time at the end talking about what we're doing about scheduling or postponement of scheduled surgery and how that's affecting things right now. And also my thoughts about potentially where we're going to end up with this in the future, which I think is going to be the real challenge, is how we're going to get caught up with this. So next slide, please. So in Alberta, we're really fortunate that we've been working on wait lists, trying to figure out, how patients are waiting for surgery. And we've been doing this for a number of years. So every patient that's scheduled for surgery in Alberta is given a code. It's a 4-digit code. And with that code, there's a amount of time that's expected that patient is expected to be in the operating room and cared for. So for example, if I see a lady with breast cancer, they're given a code FUF7, and everybody that's in the scheduling process knows that patient needs to be seen in the operating room and operated on within a month of me seeing them and deciding that they need surgery. So there's the important date of when I've seen them, the important date of when they must have the surgery by. And then also within that is sometimes we have to delay surgery for chemotherapy or for staging workups and things like that. So they're ready to treatment. The date that they're ready to be treated may actually be a little bit later down the road. So we have a very robust data set of information about each patient that's waiting for surgery in Alberta. And it allows us to manage our wait list. For example, if I have a large number of breast cancer patients that I'm not able to get into the operating room in time, then I'm going to be asking my other breast cancer colleagues in the city to help me look after some of them, or perhaps we'll shift some of the consults away from me to some of my colleagues. Now, the important thing to understand is that this does not allow us to determine how long it takes to get in to see a specialist with a diagnosis. And that information is equally as important, but yet we're still working on ways to figure out how that is, and also what how the pandemic is having an impact on that. So next slide, please. So the way things are as of about an hour ago when I last called the Grey Nuns Hospital, and it's really important for everybody in the audience and all Albertans to understand that this is a rapidly evolving situation. And as it stands right now, we are We have a whole team of nurses and physicians and surgeons and anesthetists that are looking at this and doing everything we can to make sure that minimal harm comes to you while you're waiting for surgery. So it's important to know that emergency surgery continues. So if you have appendicitis or cholecystitis, or you have a brain bleed or some cardiac event or something, you will still be cared for. And so we don't want people waiting at home with symptoms and sort of triaging themselves, so to speak. We want you to go get the care that you need. So one of the things that we've seen in previous waves that has been challenging is patients sitting at home with symptoms that if they had presented to hospital earlier, we would have been able to intervene earlier and perhaps got them home sooner, and therefore consuming extra resources. So please, if you have concerning symptoms, contact 911 or 811 or talk to your physician or come to the emergency department, and don't delay the care that you need, because it will help. So emergency surgery will continue, and we're going to do everything we can to make sure that that continues at all costs. Now, as we've seen more of our nursing staff, our anesthetists, our respiratory therapists be redeployed out of the operating room into the intensive care units and some of the extra capacity places that we've mobilized, our ability to provide surgical care has shrunk. So we are now at a much reduced capacity in terms of number of OR theaters that we're able to staff and provide. And for that reason, we're having to figure out what patients will benefit the most from surgery and trying to hopefully prevent people being harmed from having to wait for it, wait for their operation. So as it stands, as of right now, today, we are still able to do life and limb saving surgery, or a delay of more than 2 weeks would adversely affect income. So things like life-threatening vascular problems and cardiac problems and things like that. So we are still, people that have the ACATS code where it's life and limb less than 2 weeks, we're still getting those done. Cancer surgery where any delay will affect prognosis, those will be prioritized as well, and or a delay of up to 4 weeks is not expected to affect prognosis. So if you have breast cancer, we will still endeavor to make sure that you have the care that you need, colon cancer, things like that. Unfortunately, as this situation evolves, the lists are growing of people that need surgery, and we still have a finite resource. So we have teams of nurses, of physicians that are triaging the people on the waiting list and trying to figure out who needs to go first from the top to the bottom, which is obviously a monumental task, extraordinarily stressful for everybody that's doing it. And I really give kudos to the nursing management teams and physicians that are doing this work, because it's extremely stressful work. So we are trying to get that up and running. Can you bring the slide back up for me, please? I lost the slideshow.
It will reappear momentarily.
Okay. So there we go. Oh, yes. The final thing, two things I wanted to talk about is that one of the things that is always complicated when there's a lack of inpatient bed space is there are a number of these cases that require inpatient beds. And so we need to really kind of manage the patients waiting for surgery that require admission. So we can't have 10 cases in one day where we expect them to, for example, need a hospital bed after surgery. So that adds to the complexity of the decision making. So, day surgeries are easy to deal with, but if you need to be admitted, it makes it much more complicated. And the final thing is that Alberta Health is committed to making the process across the province equitable for all Albertans. So your chance of getting surgery will be the same no matter where you live in the province, and how that rolls out will be ultimately one of the bigger challenges. But we want to make sure that everybody understands that you will get your surgery with the same likelihood whether you live in Calgary, Lethbridge, Medicine Hat, or Edmonton, for that matter. My final thoughts about this is where we're at right now, and obviously this is an evolving situation. By Monday we may have all of our OR theaters filled with ventilated COVID patients and not be able to do any more scheduled surgery. it's so we're constantly reevaluating things. We're trying to figure out where things are going, and trying to figure out the best methods to look after things. My biggest concern about where this is headed, though, is that we are seeing a bigger and bigger backload of patients that are waiting for surgery. And at some point, we're going to need to figure out ways to look after these patients. And the issue will be, we have an already exhausted and depleted workforce. And as this pandemic rages, it may be possible that surgeons will get ill as well. I'm 6 months away from my last shot. So will I get COVID myself and get ill? So these are all concerning things about today, but also in the future. Is how are we going to get enough staff back healthy to be able to do the massive extra work that's going to be necessary, not only to look after people that are waiting today, but also have been waiting for surgery that haven't been able to get in. And that's going to be the major undertaking that this government is going to need to figure out in the very near future.
Thank you very much for that overview. We've talked a lot about some really big, heavy, dense happenings in our province during this conversation today. And before I bring the rest of our medical team in for some questions, we're going to take a moment and talk with a couple of patients who have been dramatically affected by what is happening in our healthcare system. I would like to introduce you all to both Rachel and Eric, both of whom have had delays on procedures over the last week as things have really started to get into that critical state. Thank you both very much for taking the time to be here today. I'm a person who really likes people, and so it means a lot to me to get to hear from both of you and how this experience has been impacting you guys. Maybe if it's okay with the two of you, we'll start with Rachel. And Rachel, maybe you could tell us a little bit about your story, and then we'll move into Eric's story.
For sure. Happy to share a little bit about it. So my background is actually for about 14 years, I was lucky enough to care for a young man who was medically complex, but unfortunately passed away last year, last August. So we just passed the first year mark as a bereaved parent. And right around the same time, I actually got diagnosed because one of the things caregivers have a real tendency to do is to ignore their own healthcare. Because they're so hyper-focused on their kids. And so I thought, dang it, it's kind of time for me to actually go start taking care of myself. So I went in for a checkup. And they asked me whether or not I wanted to start, because I'm 41, whether or not it'd be worth talking about getting a mammogram. And I thought, well, why not? I have a few complexities from adolescence, and I thought it's probably good to kind of do my due diligence, and went in, and they ended up finding a bunch of calcifications, which in some respects didn't surprise me, but at the same time, it kind of felt like a slap in the face from the universe. I spent about 7 years doing serious palliative care for my son. And I was kind of at a point, a year later, like I just wanted an opportunity to go live my life. I did great by him, and I know now is the time to do great by me. And so when it came to having to wait for the surgery, it kind of brought back a lot of grief. I don't blame doctors. I don't blame physicians. I don't blame hospitals. I've had a permanent relationship with healthcare for my entire parenting career. Planning on joining the team of all things with all the stress of COVID. The fact that I very much want to jump into and things like medical school down the road speaks highly to how I feel about everybody who is caring for patients right now. But yeah, to have to wait was just a real hard thing to deal with, just given my prior experiences, and to have to sit and kind of figure out whether or not it is breast cancer, and what next steps are, and kind of figuring out whether or not it's going to be me being sick for the next little while, or whether I can plan for a future. So that's kind of the short version of my story. Oh, you're on mute.
It's because I am projecting that I am not in the digital universe and that we could be sharing this space in a non-digital fashion. Rachel, thank you. We've had the opportunity with the POP AB briefings to talk so much with wonderful experts, but have not had the same opportunity to talk about individual Albertans' lived experiences from the other side of that, from the patient side. And I am just so thankful that you offered your strength and your story for everyone at home today.
Thank you. I appreciate that.
I'm going to bring Eric back into our window, and then I am going to bring you back into our window again shortly, Rachel. Hi, Eric.
Hello.
Thank you very much for being with us today. Some folks watching might have heard a little bit or a lot about your story. I will, if it is okay with you, allow you to recap what the last week in particular, but more so the last while has been like for you. Yeah, as opposed to me attempting that.
Yes, I'll presume not everyone has heard my story, so I'll start with back in end of June this year. I had what I learned was a seizure. I went to the Strathcona County Hospital here. I got a CT scan done, and they told me I had a brain tumor. I was moved to the University Hospital here in Edmonton, had an MRI, and they confirmed that I had a tumor. They kept me overnight and met with a neurosurgeon the next day. He told me that he wasn't going to do surgery right away, that my case would go to the tumor review board, and then they'll get back to me on what the next steps would be. In the beginning of August, I had a visit to the Cross Cancer Institute. They've informed me that surgery is the best course of action, and especially because they need tissue to determine what sort of radiation or chemotherapy treatments they can start me on. Certain brain cancers of different brain cells react better to some treatments than others, so they need that info. So I originally had a surgery scheduled for I can't remember the date. It was about a week ago now, Wednesday. Less than 24 hours before, I got a call saying that my surgery has been canceled. They didn't have a follow-up date at that time. Obviously, that put me in a lot of stress. Yes, I saw my... Yeah, go ahead. You can put that up there. That's my tumor is. It's between the right frontal and temporal lobes. The imaging is flipped. But I've been told it's about the size of a tangerine or mandarin orange. And so far it's affected things like I've been having trouble coming up with words. My coordination is off, and some other things. The day I was supposed to have a surgery, I spoke a lot with some of the news outlets here in Edmonton, and I imagine some people saw me on the television. That evening, I had the worst seizure I've ever had. It's the first one where I've convulsed. Convulsed for about a minute, then the aura and everything else didn't disappear till about 5 minutes. I was rushed to the university hospital. Unfortunately, because of the ongoing situation, it took me a number of hours before I could even get an emergency room bed. Again, they were very busy. Their waiting room was overflowing into the stollery area. So, thankfully, when I was there, heard that they had picked a new date for my surgery, which is next week, Wednesday. Of course, when we hear about these upcoming possible surgery cancellations, it's hard.
Thank you, Eric.
And just one more thing. Since ideally, my neurosurgeon informed me that ideally I would have been admitted and they could possibly squeeze me in earlier, but there was no room in neurology at the time. So.
I really, really, really hope that next Wednesday is the day that you will get to safely move to the universe of tumor-freeism.
Thank you. Or at least at the start, because they can't surgically remove it all. So
at least some more answers for you in terms of knowing what those next steps are going to look like. Myself as a human knows that I personally do best when there is a path and a plan and something that I can at least put my feet in front of each other towards. And I can't imagine how September 7th must have felt when you got the phone call about September 8th and how this last week has been. That unshakiness of a path is always one of the hardest to swallow.
Yeah, when I got the phone call, I was probably physically shaking for the hour following. It was hard. It was very hard.
I'm going to bring all of us back into this conversation as we approach just after 5, but we lost some time to technical difficulties. Before we say goodbye for the weekend, and given how much we have attempted to cover today to answer as many questions as we can for folks before we don't appear for the weekend, what is everyone thinking right now, I guess? What would everyone like to leave Albertans with as we move into some truly unprecedented and different times?
Can I go first?
Please.
As a surgeon, I'm touched by both of your stories very much, and it really puts a personal perspective on conversations that we as surgeons have all the time with our patients, and having to try to explain the unexplainable to you. And thank you both for being so understanding of a very difficult circumstance. I would like to leave all Albertans out there that are watching this, and hopefully there are some vaccine reluctant people that are watching. it's important to understand that your decisions are impacting people. And it's really hard to understand that when you're trying to make a difficult decision, especially when there's so much misinformation out there. I think it's really important to understand that that these lovely people are both in this situation because our hospitals are full of people who have not gotten vaccinated. And if everybody had gotten vaccinated when it was suggested, and we had kept looking after our population with the physical distancing measures that we set out with, I think that I know we wouldn't be in this circumstance right now. So I think this is the most important takeaway from this conversation is please, please, please get vaccinated. It's far too late now to prevent the disaster that's unfolding in front of us, but at least it will take the steps towards some recovery so that we can all start to build towards a healthy healthcare system again.
Thank you.
I'd like to thank Rachel and Eric. You both showed incredible vulnerability, which I think is something that Albertans need to see, that you are everyday people that are being affected by this, and hundreds and thousands of other patients who are being affected by this, kids, adults. And I just want to thank you for that, because it's incredibly powerful. We as physicians, we get to see patients at their most vulnerable stages, but we don't get to share the stories for confidentiality and for many other reasons. And so I really thank you for sharing your stories. And I think the other thing that I'd like to leave Albertans with, and I think this has been alluded to, is that we as healthcare providers do not need patients to self-triage themselves out. We really, really appreciate that the majority of Albertans have done the right things by continuing to mask, physically distancing, getting vaccinated. You do not need to create capacity for us in the hospitals. That is not your job as Albertans, as patients. We are here to help you. So please, if you need the help, if you need to be seen by a physician, call 911, go to the emergency room. It is not your job to make sure the system stays safe inside the hospitals.
If I could just talk as well, I think, the one concern I've always had with social media, for example, is that it's always been just numbers about how many are vaccinated, how many unvaccinated, how many in ICU, how many we have in the hospital. But I think those numbers don't tell the story. And I think for people like you, both Eric and Rachel, to come on here again, show an incredible amount of bravery, but it really highlights, I think, that these are not numbers, these are people, and they each have their stories, and we see them in ICU all the time. We see them in the hospital, and we have people like you guys who are waiting to have these things done that will improve your quality of life. And so we know these are not numbers, these are stories. But I think having people like you really show that is what really matters. That we are all citizens of Alberta, and we all have the right to a quality of life and to length of life. So I want to thank you.
I get thinking about something that the photos that Dr. Schwartz was sharing earlier, and it actually got me thinking about the first time that watching my son code. I saw him flip over, his eyes closed, and then the alarms went off, and I had just enough presence of mind to know that I needed to get the blankety blank out of that room while it was flooded with several people all at once. And it was one physician who had enough to understand that he needed to talk me through the panic that was in my eyes, the unbelievable shaking, and just asked me a bunch of random questions and things like that. And I also know that that is an idea that people think, oh, you're a parent who's a superhero. And I heard that for so many years, but at the same time, people don't see that picture. They just don't understand it. When my son had a stroke, they said, oh, so he actually did have a stroke. And they're like, no, I'm just here for the coffee. That's not how these things work. Real things happen in real time. And you want to have the reliability that you will have space to be cared for, because when you are cared for in the most beautiful dance that anyone can ever have a privilege of experiencing. But these wonderful physicians also get tired of dancing, and we want to make sure that they have enough energy to make sure that they can dance with everybody.
So again, I'm going to echo everybody else and just thank Rachel and Eric for sharing your stories and your vulnerability. It really does have a big impact on us and hopefully people listening at home. So my takeaway is it's going to be disappointing for people because we thought we were past this, but I think it really is time to hunker down. Whether you're vaccinated or you're unvaccinated, we are in such a crisis, and hopefully we've imparted that on you today, that we really can't afford a breakthrough infection. We can't afford, individuals to become infected now, because if you land up in the ICU in 2 or 3 weeks, or if your loved one ends up in the ICU, there's going to be a very real chance that we may not be able to look after you. We'll absolutely do everything we can. As Dr. Bakshi said, it doesn't matter if you're vaccinated or not. We're going to do our best to care for you. But the reality of it is that we're running out of beds, and so it's truly a disaster zone. Hunker down, pick a Netflix movie, order in, tip well to your delivery driver. We're going back to March 2020 style lockdowns. Whether it's mandated by the government or not, this is the right thing to do to protect yourself and others. So thank you.
No, I'd like to say that this, for everyone, but especially our healthcare workers, this has been a very, very long 19 months. Please be kind to one another. Show each other grace and compassion whenever you're able, and just take care of each other.
Thank you, everybody. All of our panelists, our doctors and experts, and our patients who were willing to show the faces and the stories of the individuals who are really affected by what has happened over the last week. We will be back next week. Randy will be away next week, and we will be joined by another member of the deaf community. We would like to express our deep gratitude for Randy and everyone at the Choice of Interpreters for their flexibility and assistance in helping us with our briefings over the last few weeks. Until next time, remember, COVID-19 is airborne. Wear the best available mask you have access to. Vaccinations really do save lives. So do doctors. So please seek help if you need it. Stay at home, stay safe, and we'll see you next week. Thank you, Alberta.